So thank you very much. So I should start by sort of making my apologies that I'm not a clinical pharmacologist, and there's clearly lots of pharmacologists and clinical pharmacologists in the room. So I've come at this from very much the disease perspective. Hopefully that won't come across too much in my talk. So I've been given, I think, probably the hardest task, which was to think around pharmacogenomics of drug efficacy and inefficacy. And I'm just going to base my talk around a fairly obvious framework, which I'm sure you'll all be familiar with, and I won't labour this, as I'm sure you all know it. But essentially, there's many aspects whereby drugs can be effective or ineffective. The drug has to get to the site of action and is obviously subject to a whole variety of different pharmacokinetic processes to get there. The drug has to be taken in the first place. And then once the drug does get to the site of action, it obviously needs to elicit its effect, the pharmacodynamic aspects. And I've split this down, and this will be obvious later as I progress through the talk, into sort of non-etiological and etiological aspects of pharmacodynamics. And I'm going to be focusing the latter part of the talk around etiology and how that alters drug response, particularly thinking around common complex disease. There's so many drugs, and obviously there's no way that we can cover all the drugs today. And I've just picked a few examples to talk through, which I think are potentially the most tractable in terms of applications of pharmacogenomics, or where there seems to be a lot of literature around, particularly thinking around antidepressants. So I'm going to cover primarily clopidogrel, tricyclics, SSRIs. I'm a diabetologist, so I have to slip in some pharmacogenetics on sulfonylureas and metformin. And then, as I said, I'm going to focus on etiological contribution to pharmacogenomics, again focusing on diabetes. So that before I do, I think it's important just to think around some scenarios, because I think this is really key to how we think about implementing pharmacogenetics within the NHS. And there is this sort of traditional scenario, which I think most people would think of, which is we want to start a new drug. Before we start the drug, we want to do the genotyping. That might be point-of-care genotyping. And then we use those results to guide the drug choice or dosing. There is a newer approach, which is preemptive, where essentially the genotype is already known. And therefore, when the genotype is already known, when the patient needs a new drug, that information that's already known can be used to guide the drug choice or dosing. And there is a third category, which I think is important, but maybe harder to sort of rationalize in terms of effectiveness and cost effectiveness, is around sort of after the event. And this is easier for Munir's talk when patients may have had severe ADRs, but if we've got someone who's particularly sensitive or not responding to a drug, wouldn't it be nice to be able to do their genotyping then, if we don't already know it, and use that to explain the outcome or guide future treatment. So, as I say, I think I've got the harder job, because for Munir, there's a number of good examples where genotyping up front is effective and cost effective. But I think for drug efficacy, I don't really think we have any, or maybe very few, that we can apply this approach to. I think that we have lots where we can apply this approach to. And there are possibly some areas where we can apply this approach. So just to follow on preemptive genotyping, so obviously part of the rationale for being here in the group forming was on the basis of the 100,000 genomes. And people have sequencing done now as part of that, or as part of any other clinical initiative with whole exome or whole genome. And on the back of that, there may be incidental findings, essentially, that are actionable. Or we could move to a different model, where we undertake sequencing or a genome chip preemptively. Now, this may be used to identify disease-causing variants, but it could be used to identify actionable pharmacogenetic variants. And I think this is worth flagging, that the cost, not of sequencing, and the costs of sequencing are obviously dramatically falling as well, but the cost of these genome chips are dramatically falling. So for £25 now, we're just about to run per chip, 25,000 GWASs on a Scottish population, has got all of the ADME variants on. So for £25, you can get all of the ADME content. So I think we're at a point of really a dramatic paradigm shift in the utility of genetics in clinical care, particularly pharmacogenetics, because at the point that this is done, and you could argue when this could be done, it could be done on everybody when they first develop their first disease or get their first drug, or when everyone hits 40 or 50. But essentially, if this is done up front, then at the time that you go to prescribe, there are no additional costs and there's no delay, and particularly if that's embedded in a clinical decision support system, then as the GP goes to prescribe, they will be given that information and be guided as to what the best treatment would be. Obviously, we still need the evidence that genotype-guided prescribing improves outcomes, and I'll come back to that. So I think for purposes of the rest of this talk, I think a lot of what I'm going to be saying applies to this sort of model. This was a plug, a shameless plug for what I think is a fantastic resource we have in Scotland, which is SHARE. And this, we should be at our 200,000th participant by March, or by end of March. And this is a recruitment register, but importantly, people consent for collection of leftover blood. So whenever they have routinely taken blood tests, we collect the blood, which we can obviously use for genetics and non-genetic information. And they consent for use of that genetic information in their clinical records. So as a consented data set to pilot introduction of genotype-based prescribing, this is a fantastically useful opportunity. And we're hoping, if we get our negotiations right, that we should be running that sort of £25 chip in about 100,000 patients over the next year or two. Okay, so moving on to the schema that I talked around, and this is sort of the traditional pharmacokinetics, what I've called a pharmacological perspective, the PK/PD approach. And I'll just talk through some examples here, and I'm going to talk about initially clopidogrel and then the antidepressants. So clopidogrel is a widely used drug. It's a antiplatelet drug that's used post-stent, acute coronary syndrome, post-stroke. And as I'm sure many of you know, it's a prodrug, so it has to be metabolized to become active. And you can see lots of potential CYPs involved in the metabolism, but the key one is CYP2C19. And essentially, CYP2C19 is highly polymorphic, and I won't go through the details of the table other than to say that at about 30% of Europeans and Africans are star 2, and the star 3 is much rarer. But there's a reasonable number of people who carry 1 or 2 copies of reduced function alleles in CYP2C19, and then there is a group who are these sort of ultra-rapid metabolizers as well who carry the star 17. So you clearly need to metabolize clopidogrel to work, and if you carry a star 2 or star 3, you're not going to metabolize it, it's not going to become active, and theoretically it won't work. And that, I think, is fairly widely established. Many studies have established this now, and this was just a meta-analysis of post-stent, and really the strong evidence is for post-coronary stent, and showing that if you are given clopidogrel and you are star 2 homozygote, then your odds of having stent restenosis is very high, 4.6-fold, or if you're just a star 2 carrier, 3.5-fold. Different studies have different levels of risk, but I think it's pretty clear that if you knew your CYP2C19 genotype and knew you were a poor metabolizer, you'd probably be shouting for something other than clopidogrel. There's some data around stroke as well, and this is actually data from Tayside in Scotland using electronic medical records and genotype information that we have. And stroke is interesting in that certainly Tayside and pretty widely the UK guidelines are that you should get clopidogrel after a stroke, not aspirin, just clopidogrel, so there's no dual platelet treatment. And on the back of that, we see again large hazards for recurrent stroke in patients who carry a STAR2 allele in CYP2C19. So again, if I were a patient who carried a STAR2 allele, I would probably be arguing for something other than clopidogrel. I think clopidogrel is a really nice example because it has been taken through to what I think is the definitive that we could arguably expect of all of our drug-gene interactions, which is that there has been health economic analysis done, and essentially there's a number of different models that have been applied, but this is one comparing clopidogrel with prasugrel, and basically the model was that if you are reduced function CYP2C19, then you'd get prasugrel rather than clopidogrel. And it shows that it's cost effective at 30 days and at 1 year. And even better, there is actually an RCT of genotype-based prescribing ongoing that apparently reports in March 2020, a large study which I think should be, one would hope, the definitive that will establish this as clearly a test that's worth doing. Whether or not it's a test that we should be doing on everybody who's about to get a stent, I think I would probably want to know, but that can be debated later. Tricyclic antidepressants, so just to cover these, and this is an area where I think there's a huge literature, but I'm not convinced the evidence is so strong. Just by way of background, I'll talk you through the metabolism of these. So they're the tertiary amines, and the best studied are amitriptyline and imipramine, which are metabolized to secondary amines, nortriptyline and desipramine, which are also active. And all of those essentially are inactivated by CYP2D6 to less active metabolites. And there are, of course, other tertiary amines, which are all metabolized in a similar sort of way, some more complex than others. So one of the first troublesome things around this is that amitriptyline and nortriptyline are both active. So there's a lot of work done around CYP2C19, but it's hard to predict quite the ratio of amitriptyline to nortriptyline, and I think the pharmacogenetics around CYP2C19 is harder to explain and certainly harder to think about implementing, whereas CYP2D6 clearly is inactivating our tricyclic antidepressants, so you would argue would be a prime candidate for pharmacogenetic implementation. So just focusing on amitriptyline, as I've just said, around CYP2C19. So the guidelines say that if you are a poor metabolizer at CYP2D6, so poor metabolizer of amitriptyline, you would have increased concentrations as you'd expect, and the concern with the tricyclics by and large is cardiac toxicity, widening of the QRS. So the guidelines suggest use an alternative that's not metabolized by CYP2D6, so citalopram or sertraline, or reduce the dose by 50%. If you are a ultra metabolizer, then the guidelines are to avoid. But actually, the alternative is to increase the dose. But there's a danger of increasing the dose in that you pump, you increase these other metabolites which are thought to have increased cardiac toxicity. So the outcomes there become a little bit confusing. So should we be testing preemptively? Should we be doing this before we start tricyclics? I don't think the evidence supports it. Interestingly, you look at pretty much all the studies are focused on PK. There are the number of studies that show increased side effects or altered efficacy are fairly limited, and the cost effectiveness, there are very few studies out there, and the one I saw was again fairly limited, and I don't think there's been a genotype-based trial that I can find. So this was the largest study I found, which was a retrospective study from the Rotterdam cohort looking at 807 patients, and you can see that there is an increased risk of switching, although the numbers are tiny, and probably more convincing, there is reduced dose escalation in the STAR4 variant carriers. So there is evidence, but I don't think it's superb. Just to finish with antidepressants, and the story just really gets more confusing. We have the SSRIs, which are metabolized in different ways. I just wanted to highlight, I'm not going to go through all of this, just to highlight two things I think were interesting and also make it hard to extrapolate from simple PK studies. One of which is that, for example, fluoxetine and paroxetine inhibit CYP2D6, so essentially they result in a poor metabolism phenotype. So while single-dose PK studies show big differences if you look at single dose, or if you do PK studies looking early, you see big differences. After a while, you see much less differences, so the PK doesn't necessarily translate. However, there are studies that show fairly convincingly that if you're a 2D6 ultra-metabolizer, your paroxetine levels are pretty low, so you're not likely to have much benefit. And probably the best study within this space of SSRIs, SNRIs, is a study on venlafaxine, which basically did look at reasonable numbers in randomized placebo-controlled studies, 460 patients. So this is probably one of the most robust studies around, showing that if you are essentially a normal metabolizer versus a poor metabolizer, you have lower concentrations of venlafaxine and a greater response. So there is good evidence there. How am I doing for time? 5 minutes? 10 minutes? 5 minutes, in which case I shall go fast. So just to highlight, because I'm a diabetologist, that this applies across many drugs. The rosiglitazone story is interesting because what we've done is look at both the transporter and the metabolizer. So the people who respond less well take the rosiglitazone into the liver very effectively, but don't metabolize it. So, which way around would it be? Yeah, essentially the rate at which they take it in, the rate at which they metabolize it varies. And for sulfonylureas, CYP2C9, which again is highly polymorphic, 6% of us carry 2 or 3 copies, 2 copies of the star 2 or star 3. They are much more likely to respond to sulfonylureas. I think for interest of time, I'm going to skip through this, which is always gutting for me not to talk about metformin. So I think just sort of finishing the PK aspect of this, I think my reading of the literature is that there are a lot of guidelines that recommend genotype-based prescribing. A lot of them are based largely on PK, and there is some outcome data, but maybe not robust outcome data. And then we touched upon this earlier, and I think this is something we can discuss later. But is that enough to implement genetic testing within the NHS? And there may be examples where it is, where you might call it a no-brainer. So if a drug is metabolized to very low levels, or if a prodrug is clearly not metabolized, then maybe you don't need the convincing evidence in terms of health outcomes. But I'm sure many purists would say you do. It's far too easy to assume that PK extrapolates to PD, and the metformin example was the example I was going to give there, where actually PK doesn't map to efficacy. Really we need to be thinking around getting evidence for clinical implementation requires evidence of improved health outcomes and cost effectiveness. So moving on to common disease. I'm not going to talk about cancer because that's talked about tomorrow. And so I'm going to focus on monogenic disease, but primarily complex disease. And this is just one slide by way of example. I'm sure there's many monogenic diseases you can think of, but of course, identifying monogenic disease is the perfect recipe for designer therapy, because you can develop the designer drug to deal with that disease. And there's many good examples there. But complex disease is much more complex, and it represents the major health burden, I would suggest, to the NHS. So there are many complex diseases, and again, I've put up a list, but diabetes is what I'm going to be talking around. But the theme across all of these, and the theme I want to just bring out now, is around getting the right diagnosis, that common complex disease is complex, that a stratified approach can be cost effective, and that pharmacogenetic effects do have the potential for clinical impact. So just making the diagnosis first, and again focus on diabetes, but I think you could easily superimpose many common diseases here. we've been overly simple as diabetologists, and we've limited ourselves to type 1, which we make on a clinical basis. Type 1 diabetes, and if you don't have type 1 diabetes, you have type 2 diabetes. It's as simple as that. And I think historically that's maybe served us well, but it means that we're left with this big block of diabetes that etiologically is clearly not the same condition. This is a clinical example that highlights to me why making a diagnosis matters. And again, I won't go through this in detail. I'll just highlight that this is a lovely 87-year-old lady who has had diabetes since the age of 18. A colleague in Forth Valley in Scotland referred her to me because he'd been asked to see her and thought it was a little bit odd that she was still just on once daily insulin, and that she did have quite a striking family history of diabetes, and that she's still producing her own insulin. So a simple test that isn't routinely done in diabetes medicine established that she doesn't have type 1 diabetes, because type 1 diabetes patients do not produce insulin after 59 years of having diabetes. So she was found to have a genetic form of diabetes, monogenic diabetes. And essentially I showed a number of years ago that these patients don't need insulin. They can be managed with sulfonylurea treatment. And on the basis of this, her insulin was stopped and she was given 20 milligrams of glycoside. So a lot of what I do is go around banging the drum around doing simple diagnostic tests in diabetes, such as antibodies and C-peptide, because if someone had done her C-peptide 20 years ago, then maybe she wouldn't be on insulin. Having said that, she's done pretty well on insulin, so maybe she's been on the right treatment. And there's lots of patients who get mislabeled as type 1 or type 2 who require different treatment. But monogenic diabetes, of course, is rare, and polygenic diabetes is much more common. And the problem with polygenic diabetes is we're never going to get such big effects because we've not got single gene defects with big pathophysiological variants. We've got a palette of different features or pathophysiological defects. So we're never going to see drug effects the same that we see in monogenic diabetes. And the other problem that we have is that we also have a phenotype in terms of drug response that's hugely variable. And as you start to model drug response and you've got such a variable phenotype, it makes it very hard to predict who is a responder and who is not. I'm going to skip through this. Go and see Munir is sitting on the edge of his chair. I've just... 4 more slides, Munir. So this is my vision, which is we have essentially a clinical decision support system that does incorporate, like people were suggesting earlier, renal function, BMI, all the clinical parameters that are really important, but it incorporates genotype and biomarkers. And it's never going to say this person is going to respond to drug A. It's going to say they're likely to respond, or the probability of responding is X, not Y. So that's what we're hoping for. The focus obviously has been on genetics. But actually, we haven't even done the simple stuff yet. Certainly in diabetes, we haven't. I would say that we probably haven't in many aspects of disease management. So this data just shows the difference when you look at obesity and sex in how people respond to sulfonylureas and thiazolidinediones. So slim males respond much better to sulfonylureas than TZDs. Obese females respond much better to TZDs than sulfonylureas. So those are quite big differences without doing any genotyping. And another key point I would like to get across is around the cost effectiveness of stratification. So we've been doing some work in this MRC-funded mastermind consortium where we just take a hypothetical example. We look at lowering HbA1c by 2% more. So one drug lowers HbA1c more than another drug, and it's just by 2% for 1 year. So it's quite a large effect, but for 1 year, and then that effect is lost. Now, if you take that into the UK-PDS outcomes model, the quality of life benefit for one patient, of course, is tiny, but that's probably one patient being prevented from having an amputation in 1,000 patients. But because diabetes is such a prevalent disease, if you extrapolate this out across a population, so if you imagine that this could be achieved for 10% of the diabetic population, then that's equivalent to 3,150 QALYs. And if you value a QALY at £20,000, which is what the NHS is happy to pay for a QALY, then that values this intervention at £63 million. And if you just go back up, here was an intervention where we saw maybe on average a 0.5% difference in HbA1c over 5 years. You could easily argue that's going to be cost effective because it doesn't cost anything to measure sex and BMI. In terms of genetics, I'm just going to go through and give you one example of genetics where I do think actually, even in common disease, we're seeing genetic effects that are of size that I think would start to be useful. So this is a variant in the glucose transporter, and we're looking at metformin response here. So you can see by genotype, the difference in HbA1c reduction varies between about 1.1% and 1.5, 1.6%. So that's a 0.4, 0.5% difference in HbA1c. Now, we don't know how that would map across over time, but even if it's just an effect that lasts for a year or two, if the genotyping is free because it's already been done, or it costs £25 because of the new chip, then actually just something that people would say, well, that's not going to be clinically useful, becomes useful because it's incorporated into part of our clinical decision making at the time of prescribing. And I think at that point I should finish with conclusions. So I think there's very few variants that justify pre-treatment genotyping in efficacy of drugs, unlike severe ADRs, as I'm sure many is going to tell us. Possibly clopidogrel, possibly warfarin. But I would suggest that this becomes irrelevant as we now have the potential to implement wide-scale genotyping for ADME and common low-frequency variants. And at this point, many of these pharmacokinetic variants are going to become clinically useful. But what level of evidence do we require at this point? Is dramatic PK differences sufficient, or do we need to see the trials that establish improvements in outcome? For common disease, clearly the biggest win is going to be identifying monogenic disease, which 100,000 genomes clearly is going to be doing, or better diagnosing and teasing out those individuals from the mix of common disease. But pharmacogenetic variants are modest in polygenic disease, but if we know the genotyping already, then actually that can become effective and cost effective. Thank you.